welcome. You're listening to the Sickle Cell Action Network, a weekly internet radio show presented by Martin Center Sickle Cell Initiative and sponsored by Mass Therapeutics. We're coming to you live from Indianapolis, Indiana. We're here to serve you by providing up-to-date information and opinion on all matters pertaining to sickle cell disease. My name is Gary A. Gibson, and I am your host for the next 2 hours. Let me start by saying that I don't have sickle cell disease, nor do I carry the sickle cell trait. In spite of that, I am no stranger to sickle cell. Quite the contrary. You see, even though I don't have sickle cell, it has had a very huge impact on my life. That's true because its complications took my wife from me after 12 years of marriage. It also caused her to have a miscarriage that resulted in the loss of our twin babies that she was carrying while in a sickle cell crisis. So all told, sickle cell has taken 3 lives from me, and I feel the pain of those losses every single day. I currently serve as the president and CEO of Martin Center Sickle Cell Initiative, a community-based organization that has been serving people with sickle cell for over 45 years. Each day I attempt to transform the pain of my losses into positive energy that is focused on making a difference for those who are battling sickle cell. From being involved with sickle cell for over 40 years, I'm able to say that much progress has been made, but there is still so much work to do. This show is an opportunity to contribute to the ever-expanding dialogue about sickle cell that is taking place all around the world. Our show is about raising awareness, but it is also about so much more. I like to say that sickle cell awareness is important, but we need more than awareness. Those living with sickle cell are already aware. That makes me ask, so what are we doing for them? My answer is not enough. That's why we've named this show the Sickle Cell Action Network, because awareness without action has very little impact. We want this show to be a source of information and a call to action to help those who must live with sickle cell in their midst. We have designed this show to provide information that is beneficial to patients, caregivers, family members, and friends alike. Most importantly, we want people with sickle cell to know and understand that they are not alone. The Sickle Cell Action Network show features live guests who are healthcare providers, patients, advocates, and others who are engaged in the fight to eradicate sickle cell and ease its burden on those it affects. Today, we are honored to have a special guest who will speak with us about the emergency department. Joining me in studio today is Dr. Tyler Stepsis, Assistant Director of the Emergency Department at Eskenazi Hospital here in Indianapolis. We're happy to have Dr. Stepsis here with us today. Before we get to today's topic, however, I want to share some of our upcoming topics with you so that you'll know what we're going to be doing. In future weeks, we will cover such topics as sickle cell trait in depth, and that will be our show next week, sickle cell research update, traveling with sickle cell, connecting the sickle cell community, and many, many others. So as you can see, we're serious about sharing valuable information, and we hope that you will join us every week, same time, same station. If you've missed some of our previous editions or wish that you could listen to them again, don't worry. Just go to the Sickle Cell Martin Center Sickle Cell Initiative YouTube page, and you'll find them there. So let's get on with our show, and we'll start with this week's edition of Sickle Cell News Update. I have a good story here, one of these feel-good stories. We have talked about this particular gentleman a few times before because he gives back to sickle cell in a big way. I'm referring to the Memphis Grizzlies' Mike Conley, and he won this year's NBA Sportsmanship Award. And this story was posted on the Christian Post Contributor, and it goes like this. Injured point guard Mike Conley and his team, the Memphis Grizzlies, may be done for the season, but at least he gets something that is quite rare these days, a second Joe Dumars trophy for the NBA's Sponsorship Award. After the league officially announced Conley as this year's winner, he immediately joined an elite and rare group of players who have won it at least twice. In fact, it is so rare that only 2 other players achieved the feat throughout the award's history, Grant Hill and Jason Kidd, who won the same distinction thrice and twice respectively. Head coach Dave Jorger, via ABC News, had a lot of good things to say about his injured star. He's very deserving as just a wonderful human being, a class act on the court, the way he carries himself, and certainly all the things he does in the community, he said. Adding that Conley has done so many positive things for the team and the community for the last 9 years. The award goes with the perk of choosing a charity that will benefit from a $10,000 donation from the league. For Conley, he chose the Sickle Cell Center of the Methodist Healthcare Foundation. In the road to getting the award, Conley got 58 of the 327 available first place votes, while also receiving a total of 2,209 points from his fellow players in the league. So that put him on top, and once again, Mike Conley is supporting sickle cell in a big way, so he donated his check for $10,000 to sickle cell related cause. Another story is coming to us from the Times of India. We talk about India a lot because India has the second largest group of people with sickle cell disease in the planet. And this story reads like this: Thalassemia, anemia cases among tribals worry doctors. More than 100 gynecologists, pediatricians, and radiologists who assembled here to share their views on prenatal diagnosis and screening for infection during pregnancies have raised concern over growing cases of thalassemia and sickle cell anemia among the tribal people of Jharkhand. Doctors from several provinces within the region participated in a conference organized by the Indian Society of Perinatology and Reproductive Biology. Leading gynecologist from Mumbai and national president of the ISOPARB, Milind Shah, said many of the conditions which people mistook as natural can now be diagnosed and managed with the help of screening. The society should be made aware of the new screening technology for better diagnosis results. Shah said that there are many diseases being diagnosed due to coming up of laboratories. So certain diseases like sickle cell anemia and thalassemia are more prevalent in the tribal areas. The doctors have come across the growing number of these two cases in the state. We have found that tribal women suffer from certain diseases in the country, he said. We, with the help of the local chapter, are going to conduct a research project to find out why certain diseases are prevalent in a particular community. So we are happy to see that there are people that are at least watching and paying attention to what is happening with sickle cell disease in India, which again is the second largest ethnic group of people that carry sickle cell disease. Our last story today will be a story about a fundraiser that is taking place in Colorado Springs, and it goes like this. 16 people in Colorado Springs suffer from sickle cell anemia, a hereditary blood disorder that causes many acute and chronic health problems, including severe infections, pain, stroke, and death. This year's inaugural Ella Fest event, with dancing and gospel, jazz, and R&B music by local and Denver musicians, will help the Ella Mae Bransom Sickle Cell Association raise money for those local folks and their families. They must travel to Denver hospitals as there are no medical support services available in southern Colorado. The show is Sunday at Stargazers Theater and Events Center. So that's another good story where we have people doing something to try to raise some money for sickle cell. At this point, there is one last story that I'm going to just kind of cover for you. And we've wanted to do this before, but we ran out of time on a previous show. We want to give recognition to Yvette Faye Francis McBarnett, who was a pioneer in treating sickle cell anemia, and she passed away earlier at the end of March at the age of 89. Dr. Francis McBarnett was a Jamaican-born medical pioneer in treating children with sickle cell anemia. Her death was confirmed by her daughter. Dr. Francis, as she was known professionally, was a high achiever from the time she was a teenager and immigrating with her parents to New York City from Jamaica. Raised in Harlem, she enrolled in Hunter College when she was 14, graduating with a bachelor's degree in physics in 3.5 years. Deemed too young for medical school or even a laboratory job, she earned a master's degree in chemistry from Columbia University. In 1946, when she was 19, she became the second black woman to enroll at the Yale School of Medicine. While directing a clinic at Jamaica Hospital Medical Center in Queens, Dr. Francis was credited with successfully using antibiotics to treat children with sickle cell anemia, 15 years before the effectiveness of those drugs was confirmed in a 1993 article in the New England Journal of Medicine. During the administration of President Richard Nixon, Dr. Francis was named to a White House advisory committee whose recommendations led to the 1972 National Sickle Cell Anemia Control Act, which appropriated funds for screening, counseling, health education, and research. In 1966, while Dr. Francis was in private practice and attending physician at Jamaica Hospital, she and several colleagues established a foundation to conduct research into the disease. By 1970, 5 years before New York State mandated that infants be tested for it, her clinic had already screened 20,000 children and begun prescribing antibiotics. Dr. Francis was also urging treatment by then to allow victims of the disease to pursue their education, earn a living, and rear their families in an era when many sickle cell patients did not survive to adolescence. One patient who followed Dr. Francis' advice from childhood, Cassandra Dobson, had children, earned her doctorate in nursing, and now teaches at Lehman College in the Bronx. She says, I stayed on antibiotics for 35 years, and she said, if I hadn't, I would have died. I was told I was going to die at 5, at 10, at every milestone of my life. Dr. Yvette Faye Francis was born in Kingston, Jamaica on May 10th, 1926. She was groundbreaking as a woman, and especially as a black woman, at the very beginning of the Civil Rights Movement. She was a second-year medical school student when she wrote a letter to the Pittsburgh Courier, one of the nation's leading black newspapers, urging prospective black students to apply. She later said of her white classmates, we were a close-knit, supportive group. So we want to say thank you to the efforts of Dr. Yvette Francis McBarnett, and we wish that she will rest in peace. She did a lot for those with sickle cell. And that's our sickle cell news update for today. And we will take a break, and when we come back, we will start speaking with Dr. Tyler Stepsis. Thank you.
Mass Therapeutics is leading the way in developing treatments for sickle cell disease. We're proud to sponsor the Martin Center Sickle Cell Initiative in its mission to provide leadership, education, and support services to the sickle cell community.
Welcome back to the Sickle Cell Action Network. I'm Gary A. Gibson, your host, and I'm very happy that in studio with us today is Dr. Tyler Stepsis. Dr. Stepsis is the Assistant Director of the Eskenazi Hospital here in Indianapolis. Tremendous hospital, relatively new, and very big. In fact, I had a brief walkthrough of the emergency department not long ago, and I was really fascinated at how large it is. And isn't it like 100 or some rooms?
We went from having one of the smallest emergency departments in the city in Wishart to moving to one of the biggest. So it took a lot of us getting adjusted to taking several extra steps to do the same thing we were doing before. So
right. Well,
after some sore muscles and some muscle training, it made it a lot better, but it took us a little while for sure.
Well, Dr. Stepsis, thank you for coming on the Sickle Cell Action Network Internet Radio Show. We always ask our guests to tell us a little bit about themselves so that people can get a sense for who they're listening to. So if you don't mind, tell us a little bit about yourself. Where were you born? Where did you obtain your medical training? Anything like that.
Well, I'll take you through it. I'm from a small town called Shelby, Ohio, where I was born.
Really? Okay.
Yeah, so near Mansfield, really the only claim to fame of that area. Well, there's two. One is Mansfield Correctional Institute, and the other part is that's also where they filmed Shawshank Redemption. So there's a lot of extras from my hometown in that movie.
And you didn't make it in?
Oh, no. They definitely didn't need somebody my age at that point in time.
Okay.
So I went to college at a little school called Wittenberg University in Springfield, Ohio.
I've heard of it. Mm-hmm.
Got to play a little football there, not very well, but still got to play, which was fun. And then I went to med school at the University of Cincinnati.
Okay.
And spent 4 years there. Then transitioned over to the Indiana University Emergency Medicine residency, and thought to myself, I'm probably going to go back home after my first year. My second year, I was like, I'm young, I'm single, I'm going to go wherever I want to go.
Okay.
And my third year, by the time I got to my third year, it was like, I kind of like it around here. I'm going to stick around. So I don't know if everyone does that, but it ended up being that I chose to do that. So, and I've enjoyed my time ever since, and it's been...
Did you always want to be an emergency physician when you started into medical school, or is that something that came as you went through it?
It's something that came as I went through it.
Okay.
So it's one of those things where some people have an idea what they want to be when they grow up. Since I'd never really had any sort of medical experience before, my parents are both teachers, my brothers are teachers, and football coaches. So it's one of those things where I did not know what I wanted to be. So after going through, to give everybody background, the first couple of years, traditional medical school is book work. Learning about the body, learning about through not only studies but also going through anatomy, that kind of thing. And then third and fourth year, you get to go through your clinical rotation. So you get to do some pediatrics, you get to do some internal medicine, you get to do some surgery. And people, if they don't already have an idea what they want to do, they tend to gravitate towards something their third year. Well, I found that I liked pretty much everything. Only didn't like a few things. So it was one of those things where I kind of fell into emergency medicine because it is a little bit of everything, and you don't have to worry about about trying to manage long-term things,
Right.
which is nice. I like dealing with the acute problems,
Okay.
and then leaving the management to someone else. So that ended up being a good fit for me. So that's how I ended up where I am.
Interesting. So how long have you been at Eskenazi, and have you always worked in the emergency department there?
So the answer to that is, I've been there, if you count residency, since 2002. So the Wishard Eskenazi
Right.
phenomenon, 14 years.
Okay.
That being said, I was working out in the community out at IU West for 5 years after I graduated in 05. But I was also doing a few shifts a month at Wishard at that point in time as well. So I've always been there, but I didn't become full-time there until the 2010, 2011 year. So
Okay.
that was that's how I ended up back where I am now. So.
Okay. I think to me it seems like it takes a really special kind of person to work in the emergency department. You kind of explained sort of where you're coming from, and that you kind of wanted to do a little bit of everything, and that explains it somewhat. But what is it about you that makes you able to do what I think is very demanding work?
Well, part of it is the ability, I think, to compartmentalize things every now and then. We see some horrible stuff on occasion, some
Yeah.
stuff that if you sat down to think about it, you might say, I can't believe how that's messed up. I don't understand how anyone could do that, or how anybody could live through that. There are other times when you have to transition from something like that quickly to taking care of someone else who might have a completely different problem. So you almost have to learn how to compartmentalize a little bit. Some of us are better at it than others, and I think the ones that are good at it tend to be physicians, nurses, nurse practitioners, PAs that work in the emergency department, because you can't let one interaction cloud the next interaction.
Right.
You kind of have to brush it off and keep going. So that's probably the biggest thing that you're going to find a commonality in the emergency department, is people tend to be able to move from person to person, from patient to patient, and not let the previous interaction cloud their judgment, positive or negative.
I mean, that does take some special skills, I think. Yeah. So our show tries to provide awareness and education about sickle cell, but we also try to provide awareness and education to those who have sickle cell. Sickle cell patients spend a lot of time in the emergency department, and it might be helpful for them to understand the organizational structure. Would you please give us a guided virtual tour of the emergency department with an overview of how the emergency department is staffed, and maybe explain a little bit about the key roles that these people play?
Sure. So really, for the most part, depending on how there's different ways people can get interacted with up front. The most classic emergency department will have a triage system, so you'll check in, and then a nurse will take you into a room, and they'll do your vital signs, they'll ask you some questions, and decide exactly where you fall on a severity scale. There are others that have since done away with that and said, you know what, we're just going to get you back into a room as quickly as we can. If you look bad, we will try to take care of you sooner, or at least try to figure it out sooner. But for the most part, the more time you spend in a triage center, the less time you actually get to take, or the longer it takes to actually get to the person you're trying to see, which is the provider. Okay. So we moved to that philosophy probably 4 years ago now, maybe 5 years ago now.
Okay.
So at our department, when you arrive, especially if you ride through the front door, you're going to see registration person. You're going to see usually a nurse, or sometimes it's a paramedic, depending on who we have filling that role that day. Okay. And they're going to ask you a couple basic questions. Hey, why are you here? And then if it's something concerning, say chest pain or shortness of breath, they might ask you a couple follow-up questions. But for the most part, it goes by how you look and how you are. Do you look like you're out of breath? Do you look sweaty, ashen, pale, that kind of stuff? If that's the case, then definitely the wheels get in motion a little bit quicker.
So that is the triage nurse that is making that initial.
Yeah, no, that in a traditional emergency department or a traditional triage area, that would be the nurse grabbing you, taking you to a room, doing those questions. Up front, it's basically a first look.
Okay.
Almost in the ethos of Malcolm Gladwell's book Blink. Okay. Where it's one of those things where, yes, I know it says don't judge a book by its cover, but 90% of the time you do a really good job of judging a book by its cover. So yes, it's kind of in that same vein. And there's been some literature lately that says that that's probably the way we need to go. Okay. The triage model is somewhat outdated. Really, you just need to get people back to the people who can help them. So once you get to that area, if there's an open bed, they'll take you to it. If there are certain complaints that might need, say, a heart monitor, They'll take you to a certain area if there's a bed open there. If not, they'll take you to another area where there's a heart monitor. But those typically get back a little sooner anyway.
Okay.
Once you get into a room, at least at our shop, then that's when the official kind of, we call it intake process starts. So the nurse will, depending on who gets to you first, if the nurse gets to you first, she'll ask a set of questions, do your vital signs, try to decide whether something needs to be seen more urgently or not, and go from there. If the provider sees you first, they'll go in and do the stuff the provider normally does, ask you questions, do a physical exam, decide, hey, this is what I think needs to happen. Wait for the other part of it to happen, the vital signs and whatever, but the orders get put in at that point in time as well.
Okay.
So no matter what happens, the provider's putting the orders in. After the orders get put in, then the nurse will see the orders and start the workup, whether it's putting an IV in someone and giving them fluids or medications or whatever, or say you have an asthma attack, starting a breathing treatment at that point in time. Sometimes it's, although you look healthy, you definitely are not very healthy. Let's get you back to an area where we can do some more things immediately. And that's the whole point of getting someone to a bed sooner. If you can get someone seen sooner, it doesn't really matter where you start them as much as it is recognizing that someone has a potential problem.
Okay.
So once you're in a room, you get whatever treatment started, and then at our shop, either once that treatment's done, or if we have a procedure like there's a pus pocket and abscess, we'll cut that open and do whatever we need to do. Either we'll send you home at that point in time, or we'll just say, hey, this person needs some more monitoring. Let's move them to another place. So kind of in the Disney park phenomenon, as long as you keep moving, things keep happening sort of thing. So it's one of those where we'll move you to a different area to do some longer term monitoring, whether it's reassessment of pain, whether it's reassessment of how your vital signs are doing after some fluids or some blood pressure medication or whatever it is. We'll do that at that point in time, and then usually a couple hours into the stay, sometimes less, sometimes more, we'll make a decision on whether you can take care of this problem at home or whether you need to stay in the hospital because there's a problem that's either not going to be taken care of very well at home, or you don't have the resources or the backup, i.e. a primary care doctor that can get you in a timely fashion that can help you take care of this problem as an outpatient. We also have a third level, which is kind of our emergency department observation unit for people that they probably need somewhere in the 12 to maybe 24-hour category of monitoring, but they don't need a full hospital admission.
Okay.
So you might get moved to that point in time as well, to that area, rather than making a decision to fully admit you or discharge you. So that's more of our, we think there's something going on, but we're not quite sure.
Got to watch a little more.
Yeah, exactly.
Okay.
Or it's they probably just need a couple of doses of XYZ medication, and then as long as things are getting better, they can go home.
Okay.
So,
wow, great answer. Yeah. Thank you so much for that. In your opinion, what are the top 3 things that are important to the successful operation of a emergency department?
That's a great question. So it depends on what you mean by success.
Okay.
A lot of times success is the timeliness of interactions as well as evaluations of patients. Success also is defined by, hey, how quickly can you get people to their final destination, whether it's home or whether it's upstairs to the hospital. And sometimes success is just, have you made people feel better?
Yeah. Whether
it's they're still there or not. And I think there's a combination of those things. And if you're going to measure top 3 things, one is having the enough staff, both in the emergency department, but also probably more importantly, either in the hospital or in the clinic system, to be able to handle the load that's going to come out of the emergency department. Because what you feed in's got to come out someplace.
Right.
If it doesn't come out, it's just going to get backed up, and it takes longer to get people through.
Right.
So that's part of the success of an emergency department, is having the adequate resources both in the emergency department.
That makes sense. That makes a lot of sense.
Out of the emergency department to be able to handle that flow. And we talk a lot about surge capacity. Nobody ever can really run at 100%. It's like pegging your car's engine at a red line the whole time. Eventually, it's going to blow up. But if you can modulate those RPMs a little bit and say, hey, maybe if I run it at 60 rather than 100 or 70 rather than 100, I'll be able to go as fast as I can, but not worry about blowing up that engine. So, it's one of those things where that's really important. And I think another key to success really is having the right temperament for people to be able to say, we're going to take care of you, and we're gonna take care of you the best of our ability.
And that's a really important part.
And yeah, exactly. It's one of those things where and it kind of falls back on the key tenets of people that work in the emergency department, which is you kind of have to have a short memory. It's almost like a major league pitcher. I got shelled the last time out, but this time I'm going to say, hey, you know what?
Right.
I'm just going to give my best effort again. I'm going to forget about last time. Let's just go at him again this time. And then probably the third is the willingness for patients to be responsible for their own health care.
Okay.
If we ask somebody to do something and we send them home and they come back getting worse and they haven't done it, we say, hey, we gave you a roadmap. Why didn't you follow the roadmap? Mm-hmm. Well, and sometimes it's because there's been unrecognized social situations. There's been other things that have popped up, but sometimes it's like, I didn't feel like getting it filled, or my insurance didn't cover it and I didn't have the pharmacist call to request something different. So, there has to be interplay both on the provider side but also on the patient side.
Yeah, and I think you and I had a brief conversation about that at one point, and I really think that that's important, and we'll stress that as we continue on. Does the hospital track the time it takes from the time a person presents themselves to the time they either are discharged or admitted?
Absolutely.
Okay.
They absolutely do.
Okay. Thank you, Dr. Stepsis. We're going to take a break, and when we come back, we're going to continue our discussion with the outstanding Dr. Tyler Stepsis, and we're looking forward to hearing more from him as we go on with the rest of our show. We'll be right back. Hi, I'm Gary A. Gibson, your host for the Sickle Cell Action Network Internet Radio Show. If you are impacted by sickle cell disease in any way, whether you are a patient, a caregiver, or a friend, you need to join me every Tuesday at 4 p.m. Eastern Time. I promise that you will find our show to be full of information, perspective, and opinion about all things sickle cell. See you Tuesday right here on RadioNext.tv, the Cool Groove site. Welcome back to the Sickle Cell Action Network. I'm Gary A. Gibson, your host, and we are speaking with Dr. Tyler Stepsis from the Sidney and Louis Eskenazi Hospital here in Indianapolis, Indiana, and he is the Assistant Director of the Emergency Department at that big hospital. Dr. Stepsis, you sort of said something that made me think that I wanted to ask you another question. In your medical training, how much exposure is given to sickle cell when you were in medical school?
Well, that's a great question. I think a lot of it has to do with the prevalence of disease. So, if you have a high prevalence of HIV in an area, you're going to probably have a lot more exposure to that, just because on your clinical rounds, third year for medical school, fourth year medical school residency, you're going to say, I know how to treat that. Same thing happens with sickle cell. If you don't have a whole lot of exposure to it based on where you live, the training is not going to be such that it's going to stick in your mind fresh. So you may have had that training, you may have had that learning opportunity your first year of medical school, your second year of medical school, but if you don't have that exposure on a regular basis, you're going to say, hey, yeah, I think I remember how to do this, or I know the basic tenets of it, but am I nuanced enough to say that this is not going to work, or this isn't working right now, I need to make an adjustment in my care plan and go from there.
In your opinion, in that first 2 years, not when you're doing your clinical stuff, but in your first 2 years, do you think it should be more?
As with anything,
because I've heard a lot of doctors tell me we don't spend that much time on it in medical school.
I think with anything, you can always spend more time on it.
Okay.
The hard part is those first 2 years are so jam-packed with varying degrees of learnitude, so to speak, that you almost have to give the Cliff's Notes version and then expound on it as you get experience. So I shouldn't say it's Cliff's Notes version, but it definitely is. You're going to get the basics, and then as you get experience, you're going to expound on that. So, and really, for the most part, with medical school, not everyone has had a ton of science background. So, a lot of it's square one for people. I was a chemistry major, so I didn't have a ton of biology background. There are other people in my class, fine arts majors, other stuff. So, they're starting way from square one. Right. So, really, to cram all that in your brain, certain things will stick, and a lot of it ends up being experiential. So, the more you see, the more it's going to stick.
Okay, thank you for that. So you see pretty much everything in the ED, don't you? Yeah. In my mind, I can break your patients into two categories. I'd say the first is injuries and the second is illnesses. So let's talk about the injuries first. What are the most common injuries that you see on any given day? So
I could tell you probably on the more mundane side of it, it's the I cut myself or I slipped and fells that tend to dominate depending on the weather, a lot of times is
Okay.
the slip and falls.
Okay.
We see a lot more of those when it's
When the
cold
winter-
or rainy
mhm.
or sleet or ice out. On the more TV show exciting side of it, we are a fairly big receiving hospital for our gunshot wounds in the city, as well as our stab wounds. So we get a lot of penetrating trauma in that regard. We don't get as much in the car accident realm, because I think for the most part, car accidents and blunt trauma are seen as more, I guess, cookbook, so to speak, in regard to, do this, do this, do this. They rarely need an operation right away versus, if somebody gets shot, more than likely they're going to need an operation, especially if it's somewhere below the chin and above the hips there.
Okay.
They're probably going to need some sort of operative intervention, or at least some sort of continuous monitoring. So we see, as far as injury goes, probably slips and falls or some injuries, that I always like to joke, hey, the famous last words of people before they go to the emergency department is, hey, y'all, watch this. It's one of those things that's pretty common when we have that too. Hey, I was on a motorcycle and I decided to do a wheelie, and that's how I ended up cracking my head, so
Right.
that's probably the biggest dichotomy we see as far as common injuries versus the more serious.
And so then when it comes to illnesses, what are the most common illnesses you
So
see?
if you look at emergency department data, by far and away, number one is abdominal pain.
Okay.
By far and away. So we'll see, if you look at any emergency department in the country, probably, I don't know, going to have somewhere in the 20% range be abdominal pain. So it's not uncommon. Up there too is difficulty breathing. Now and then after that, you see some chest pains as well. I say some. We see quite a bit of chest pains at our center as well. So you think about the ones that are most resource intensive, it's probably those three. And then you can kind of break it out from there as far as, do people have some sort of infectious problem? Do they have a skin infection? Do they have pneumonia? Do they have, a brain infection, like what we call meningitis or encephalitis? Then, you talk about things like just not being able to care for yourself anymore. So sometimes we'll see the family drop off grandma saying, we've been trying to take care of her, but we can't provide what she needs anymore. Can you help us? And,
Okay.
sometimes it's a social thing as well. But I
Okay.
think probably a top three, at least if you ask most emergency physicians, are belly pain,
Okay.
chest pain, shortness of breath.
Okay. Of that belly pain, what's dominating in that area?
So really, for the most part, I would say probably the number one diagnosis of abdominal pain, people come in and they say, I have belly pain. Their diagnosis as they leave is abdominal pain, not otherwise specified, because we just don't know.
Okay.
It's one of those things where we're taught is, don't put a diagnosis on the chart if you can't confirm that diagnosis. So you might think this person's got belly pain because they've got of the flu, like the stomach flu, the bug, causing vomiting and diarrhea. I think that, but we can't say gastroenteritis. We might say abdominal pain, vomiting, and diarrhea.
Okay, unspecified.
But you might, in younger populations, appendicitis is there. In more middle-aged populations, although this is becoming a younger disease as well, gallbladder disease is a big one. We see a lot of infectious causes from healthcare acquired stuff. So people that have been on antibiotics for another cause, they might get what's called a colitis or an inflammation of the colon, and they cause a lot of diarrhea and a lot of abdominal pain as well. The older population, you might see diverticulitis as well, which is a special kind of, almost like little appendixes that start to form on the colon, and they can get inflamed just like that too. So there's a variety of things, and some are much more common than others. There are a lot of surgical things that I haven't mentioned, but it's one of those where even things like what we call GERD or gastroesophageal reflux disease or peptic ulcer disease can cause abdominal pain as well. So,
Okay.
Yeah.
You're very informative. Thank you for that. I read somewhere that emergency departments can sometimes get bogged down because of people who come in with non-urgent medical problems. Is that something that really happens? And if so, how often does it happen, would you say?
So I think that's the leading viewpoint for people that aren't in the emergency department. So people on Capitol Hill, politicians will say, the problem is people using the emergency department for things they don't need to be there. Yeah, there are some people that don't need to be there, but honestly, those people don't take up much of our time.
Okay.
The leading cause of patients waiting by far and away is the lack of inpatient beds.
Okay.
So what happens is if we decide to admit somebody, they don't automatically magically get whisked upstairs and go to the land of fluffiness and food. It's more of a, well, we might get a few discharges today, so then we get them out of the hospital. Then the bed's going to need to be cleaned. Then the nurse is going to have to take a report. So it might be 6 hours from now.
So hence, this goes back to your earlier statement you were making about the successful part with what's happening
Surge
upstairs.
Capacity.
Yeah,
absolutely.
Right,
You need to have some open beds at all times.
Right.
Unfortunately, hospitals don't like to run in the negative.
Right.
So I feel lucky that I work at the place I do, because the focus it seems to be solely on patient care.
Okay.
There's not a big worry of, is our overhead, is our profit margin going to be enough? It's really what's going to be best for patient care, and can we continue to do this and not have to then let people go because we can't afford it anymore? So we run a fine line, but I feel very fortunate the fact that our hospital leadership, the Lisa Harrises of the world, the Chris Reavers of the world, say, hey, let's do what we can to do what's right for the patient. And so that's led to, we're hiring more people. We are opening more beds. We actually started that hospital, we closed wings because we just didn't have the same capacity as we did in the old place.
Okay.
So now we're hiring more people, but unfortunately everyone around the city's hiring more people, and they don't make enough nurses. So it's one of those things where there's always going to be a shortage. So
right.
In a perfect world, yes, we'd say, let's get this person admitted, and within the hour they go upstairs, and that keeps the department flowing. But unfortunately, that by far and away, hospital crowding is number one. It leads to emergency department crowding, which leads to long waits.
Okay, you heard it here. That's how it works. And that's sort of what I thought, but I'm glad that you were able to explain why that is. What is then the protocol for deciding who gets seen first? You sort of touched on that, but I think we probably should go a little deeper into
absolutely.
that.
So in our system, we do it's basically a first come, first served, unless you have either a bad look about you or a chief complaint that makes us say, you know what, we need to get you seen right away. So if you're 65 or 70 years old and you're saying my chest hurts, we're probably not going to make you wait. If you're 22 saying my belly hurts and you look good, if there's an open bed, we're going to get you there. If not, we're going to get you there because you're number X in line.
Okay.
In a traditional triage system, basically it's what they call the emergency severity index. It goes level 1 through level 5.
Okay.
And level 1s are the immediate life-threatening things, the people who happen to die in front of you, the people who look so short of breath that they might be on their last breath, the people who are just pouring down sweat saying their chest hurts. They're probably going to be labeled level 1. Level 2s are, they're probably going to need to be seen within the next 10 to 20 minutes, or they have a severe amount of pain or discomfort, that kind of thing. Then after that, it becomes how many resources do you think this person is going to need? So if it's, say, this person comes in and they are complaining of sneezing, which happens, but we don't think there's anything else going on and their vital signs are okay. And then, like I said, this is a traditional triage, not what we do.
Sure.
They might be labeled a level 5, meaning least urgent. If they come in saying, I've had a cough for a week, the triage nurse might think, well, they might need a chest x-ray, which is one resource. So let's label them a level 4.
Okay.
And then comes probably the 60% of patients, which is level 3s, which are they're going to need 2 or more resources. And then they look at the vital signs, and if there are any vital signs are concerning, they might bump them up again to a level 2. Mm-hmm. So it's one of those things where, based on the ESI, there's a little bit of subjectivity in regard to how the patient looks. But the vast majority of it is, what are you complaining of? What are you telling me? What are your vital signs? And how many resources do I think you need as the triage nurse? So, as you can see, that might take a little bit of time, and that's time spent away from being in a treatment room.
Okay.
Which is why we went away from that.
So, this is one of the reasons why it's just so important with sickle cell. Mm-hmm. Because, and you hear this time and time again in the sickle cell world, is that, they don't look like there's anything wrong with them.
That's correct.
Right? Most of the time.
Right.
So then that pretty much starts them up at a higher level based on that classification, right?
A higher number, yeah.
A higher, yeah. So what would that be normally?
They probably would be a level 3.
A level 3. Okay.
Just based off of, if they say I'm having a sickle cell crisis, my normal crisis, my back hurts, my arm hurts, my leg hurts, whatever it is, and they look good and their vital signs are okay, they're probably going to be a level 3 because the triage nurse is going to say, hey, I think they're probably going to need some blood work, probably going to need some medication, probably going to need some
so they're going to require some resources.
Right, they're going to require some resources, we're going to require some time, so they're going to be a level 3.
Okay.
Now, people with an acute chest crisis,
Yeah.
their oxygen saturation, their level of oxygen in their bloodstream is going to be lower. They're going to look fairly sick because a lot of them have fever. They're working to get that kind of stuff. So they're probably going to be brought back. In our system, they're going to say, you don't look very good. Let's take you back right away and at least get you evaluated.
Okay.
If we don't have a room open, we'll get you into a room so we can get you vital signs and then decide whether we can put you back out in the waiting room or whether we need to find an open stretcher someplace. So, it's one of those things where for the most part that sickle cell unfortunately is at a disadvantage because patients have adapted to their pains so well that, a lot of times their vital signs are never abnormal. And so a lot of times we say, well, you're saying your pain's a 12 out of 10, yet your heart rate's 65 and your blood pressure's 100 over.
And your hemoglobin's still normal.
Your hemoglobin's still 8 or whatever your normal range is. So, I don't have any objective data to say that you need more than that. So that becomes the dichotomy of emergency care, especially for sickle cell. Is that patients unfortunately lie about. They're not trying to lie, but their vital signs and their general demeanor don't let us know the underlying urgency of why they're there. If that makes sense. Does that make sense?
Yes, it does make sense. And to me, what it shows is that there's still more education that needs to take place. And that's a part of what we're trying to do at Martin Center Sickle Cell Initiative. We're going to take a break, and when we come back, we'll continue learning with Dr. Tyler Stepsis.
Therapeutics is leading the way in developing treatments for sickle cell disease. We're proud to sponsor the Martin Center Sickle Cell Initiative in its mission to provide leadership, education, and support services to the sickle cell.
Welcome back to the Sickle Cell Action Network. I'm Gary A. Gibson, your host. The Sickle Cell Action Network is sponsored by Mast Therapeutics, a publicly traded biopharmaceutical company headquartered in San Diego, California. Mast is currently leveraging the molecular adhesion and sealant technology platform derived from over 2 decades of clinical, non-clinical, and manufacturing experience with purified and non-purified polaximers. Mast has developed a drug called MST-188 as a candidate for serious or life-threatening diseases with significant unmet needs. Among those needs is the treatment of sickle cell disease. Mast has enrolled sickle cell patients in a clinical trial known as EPIC. EPIC stands for Evaluation of Purified Polaximer in Crisis. If successful, EPIC could result in the first treatment of its kind to treat sickle cell disease patients while they are in crisis. The EPIC study aims to determine whether MST-188 can shorten the duration of a painful crisis. MST-188 is an investigational drug that has not been approved for commercial sale in any jurisdiction for any use. MST-188 potentially improves oxygen delivery, and it may help keep blood vessels from becoming blocked and more obstructed. It may improve blood flow by stopping cells from grouping together. It may also reduce inflammation, and it may restore cell membranes and give damaged cells time to heal. EPIC participants continue to receive their normal pain treatments during crisis, and their participation is free of charge to them. The patients involved in the EPIC study may not only be helping themselves, but they might also be helping future generations of those yet to be born. If you're interested in learning more about the EPIC study, please visit www.theepicstudy.com. We're delighted to be speaking with Dr. Tyler Stepsis, Assistant Director at Eskenazi Hospital here in Indianapolis, and he is providing us with a wealth of information. We're going to continue the discussion right now, and I'm going to say, Dr. Stepsis, I did a little research before the show, and I found a 2004 American College of Emergency Physicians article that states that there are 5 systems in the ED that affect the speed and efficiency of patient flow. You sort of touched on this a little bit. Nursing, clerical staff, lab, x-ray turnaround, chart flow systems within the department, and the speed of which residents and staff answer pages, and the time it takes to get the patient admitted. The other 50% of efficiency depends on the emergency physicians on duty that day and how they utilize and work within these systems. Would you agree with these statements? And if so, why? And if not, why not?
Yeah, I would say generally yes.
Okay.
I think the goal of any well-oiled emergency department is to make the emergency provider the link to if they're the slowest step in there, you're doing something right.
Okay.
If the provider's waiting on patients to get into rooms, if they're waiting on things to happen, and they aren't seeing new patients and making dispositions or deciding whether to admit or discharge a patient from the emergency department, then there's something else that needs to be tweaked. Yeah, absolutely. I mean, lab turnaround time is important. X-ray turnaround time is important. That kind of stuff is, although good, I mean, the static, so you can kind of plan on that. But overall, definitely, the nursing staff, nurses are the unsung heroes of the emergency department. I'm not saying that just because I'm married to one, but it's one of those things where, they get...
And she's listening right now.
Yeah, they get such little praise for the vast amount of work they do.
I agree.
They interact with the patients way more than we do, and they've saved my butt so many times by saying, "Hey, did you notice this? Or did you notice that?" So, if you have a great staff working with you, that makes all the difference in the world, and it makes my job a heck of a lot easier. So, I would say that statement pretty true. Now, the percentages, I could probably, we could tit for tat on that a little bit. For the most part, I would say, yeah.
Oh, well, and a lot of that goes back to what we were talking about earlier when you were talking about the resources, and I think that's not something that people generally think about, is the need for those resources to be available and the role that they play in how things work inside the emergency department. So let's talk about sickle cell disease now a little bit more specifically. And our understanding is that your emergency department may see more sickle cell patients than any other hospital in our area.
Could be, yeah.
At least that's the way it seems to us. So do you know about how many sickle cell patients you see in the emergency department per week or per month?
I would say we probably have somewhere between 1 and 5 patients that we see within a month. On an average. Usually it's more than once. A pain crisis tends to not be a one and done phenomenon. Unfortunately, there's several different crises that happen during the span of a couple weeks or whatever it is. So the hard part is reconciling that with the patient presentations. We try that pain crises especially are probably one of the hardest things for us as physicians, clinicians, providers, to wrap our heads around, because there isn't really a good test to say you're in crisis, we need to help you out, or you're having this problem, we need to help you out. As we were talking about before, I mean, patients are so good at dealing with their pain, whether it's mindful meditation, whether it's something else, that they all of a sudden kind of get, I guess, downplayed just based on the fact that they look so good. They can
handle it.
Yeah.
To some extent.
When we go back and say, how you feeling? They're like, oh, my pain's still 10 out of 10. We're like, but you look so good. Are you sure about that?
Right.
So that's probably the hardest part, and that's why I think there is more recidivism in the emergency department, more people coming back, is that we just don't adequately get them right the first time, and there are other multiple factors that play into account as well. But overall, I think the big thing is having that respect for sickle cell, and having the respect for the fact that people have adapted to a certain level of pain, and knowing that when they're in crisis, they're going to come to the emergency department, because that's in America, that's where acute things get dealt with now. It doesn't happen in the office anymore. So I think that's probably the biggest thing.
Yeah, and I don't know what the answer is to that. I know that there are efforts underway to try to be able to find that objective stuff, that evidence you're looking for, but it isn't there yet. And so it really comes down to having to take patients at their word.
Right. I think the other thing that would help is having patients stick with one hospital system.
Yes.
A lot of times when we look and we see a patient's been at St. Vincent's, and then at Methodist, and then at Communities, and now at us in the past 72 hours. Yeah, they could have been undertreated for their pain, but also we look at, we're like, man, who do you belong to? We need to be able to have good contact with your doctor so we can develop a good treatment plan. But if we can't continue to one healthcare system, we can't really objectively say that you are getting the optimal care. So that's the other big part is
and there's a catch-22 with that, because I've had several conversations with sickle cell patients that say, yes, I went to Community and I waited and I waited and I waited and I couldn't wait anymore, so I went to Eskenazi or something like that.
That I absolutely understand that, for sure.
So that does happen.
Absolutely.
Okay, so a 2010 article by Dr. Hussein Youssef called Emergency Department Visits Made by Patients with Sickle Cell Disease, a Descriptive Study, 1999 to 2007, says that data obtained from the National Hospital Ambulatory Care Surveys shows that the estimated yearly average number of emergency department visits by patients with diagnosis of sickle cell disease was 197,333, and that's nationally, which actually equates to over 1.5 million emergency department visits during that period of time. That represents a tremendous load on our nation's emergency departments. Even though in places like in Indianapolis or smaller urban areas, the volume isn't as large, but in other areas it's much larger.
Absolutely.
So helping to contribute to that. But that's a tremendous statistic, and that's another way of looking at it. To me, it proves that we really need to get more prepared for dealing with people with sickle cell when we're dealing with 1.5 million visits or 200,000 visits a year. Would you agree?
Yeah, I think it's absolutely true. I want to say the latest 2013 they looked at the amount of total emergency department visits just annually, all comers, and it was somewhere in the 136 million range. So it's one of those things where, I mean, it's definitely climbing, and access to healthcare insurance has been a boon for people to actually go get some of their medical issues taken care of. And unfortunately, the hard part is when you don't have a physician, you go to the place where you know you're going to get seen. So we are seeing a few more patients in that regard, but for the most part, it's one of those things that, when you start seeing a climb like that, where there's 1.2, 1.5 million people having this, or I shouldn't say people, maybe it's just visits, having this kind of impact on emergency department flow, you have to say, well, what are we doing now, and what can we do differently? And so, I think, a lot of it ends up being integrated care. It's one of those where not only what do we do in the emergency department, but what also can we do either inpatient if they get admitted or outpatient to ensure that this patient has what they need to be able to take care of themselves in the next week, month, that kind of thing, until they can see their primary care doctor again. Sometimes it's a fact of, hey, I had to make rent this month, and I couldn't afford my hydroxyurea. I couldn't afford this, and we see that a lot. It's really heartbreaking because it's one of those things where you should be able to take care of yourself, and it shouldn't be a problem in one of the richest countries in the world to be able to say, I need help. Help me. But it is, so it's one of those things where I think, for the most part, the more we can develop an integrated care platform, whether it's seeing people in the emergency department and then ensuring care. The Indianapolis EMS is a great program out that looks at people with high risk complaints, and they do follow visits for them within a couple of days.
Okay.
And so it's one of those. Right now, they've just started with like congestive heart failure.
Okay.
And chronic obstructive pulmonary disease, emphysema, that kind of stuff. So, and they do pediatric asthma as well, because those are ones that bounce back fairly frequently, especially if they don't have the right medications. And if this is a successful program, then perhaps we can start to integrate other complaints that do have a lot of emergency department use to say, hey, what is it that we can do to help you out? Is it something as simple as a social issue? Is it something that we need to help you get on your medications, or is it something else that we can do to make sure that you are healthy, are pain controlled, and are willing to, I shouldn't say willing, are able to function as a productive member of society? Because I think that's what most people want.
Yeah,
is not so much to be pain free, especially with sickle cell. It's to be pain controlled to where I can function again.
Right.
I want to be able to walk around and do what I need to do, and not think about my leg constantly, or not think about my back constantly, because I can't concentrate and do my job if that's all I'm thinking about is my pain. So it's one of those things. Hopefully, this program merits its success, and we can expand it. But like I said, that's a ways down the line still.
Let me backtrack just a little bit. We're talking about how difficult it is for you as the provider when you see someone with sickle cell and it doesn't appear that there's anything wrong with them. Are there any other illnesses that are similar to that from your perspective?
It's a great question. There are a lot of kind of chronic pain syndromes like sickle cell. I mean, I shouldn't say sickle cell is a chronic pain syndrome, but it is kind of in the respect that, people are on chronic opioid therapy, but there are things like complex regional pain syndrome. They used to call it reflex sympathetic dystrophy, where sometimes people get an injury or they've had an operation to an arm or a leg, and they have this chronic, almost nerve pain that's associated, and they deal with it for a while, but they might have an acute crisis. There are other things like fibromyalgia, that kind of stuff, where the underlying pain episode is real, but we just can't quantify that. We can't say, hey, this is what you need. And the hard part is now, especially with the heroin epidemic and that kind of stuff going on, the crackdown on chronic opiate use is such that they're asking a lot of us to say, you know what, if you can limit or not give someone opiates in your department, that's even better than giving them that to start out with. So there's kind of this competing interest, so to speak.
There's a problem right there,
Right.
because in fact it's really right now I'm starting to see some articles about that and how it impacts people with sickle cell, and it's some of them almost feel like, hey, I'm a target now because this is going to impact my ability to get pain relief,
Right.
and that's not a good thing.
No.
We're going to take another break, and when we do, we'll return and continue our discussion with Dr. Tyler Stepsis, learning all about the emergency department, and we're going to be right back. Hi, I'm Gary A. Gibson, your host for the Sickle Cell Action Network Internet Radio Show. If you are impacted by sickle cell disease in any way, whether you are a patient, a caregiver, or a friend, you need to join me every Tuesday at 4 p.m. Eastern Time. I promise that you will find our show to be full of information, perspective, and opinion about all things sickle cell. See you Tuesday right here on RadioNext.tv, the Cool Groove site. Welcome back to the Sickle Cell Action Network. I'm Gary A. Gibson, your host, and the Sickle Cell Action Network is brought to you as a service of Martin Center Sickle Cell Initiative, a community-based organization that's been providing services to people with sickle cell disease since 1970. As a result of our efforts to provide awareness and education and to provide supportive services to people, as well as to advocate all things that are within our mission, we bring you the Sickle Cell Action Network. And I wanted to certainly let people know that we recently concluded a very successful town hall meeting on sickle cell disease here in Indianapolis last Thursday with our special guest from the CDC, Dr. Craig Hooper and Dr. Mary Houlihan from the Centers for Disease Control Blood Disorders Division came to listen and learn about sickle cell disease. They provided a presentation on the things that the Centers for Disease Control is doing with regards to sickle cell, but mostly they wanted to listen, and so they listened to testimony from 5 sickle cell patients, 2 practicing physicians, and a community organization board member. And I can tell you that they were very interested, that they paid very close attention to everything that was said, and that they were very appreciative to have had the opportunity to participate. One of the things that came out of the testimony, 3 of the 5 different patients that testified really stated a need for what is commonly known as a comprehensive sickle cell center, Dr. Stepsis. And that is a place that is devoted to sickle cell disease, and it is something that we at Martin Center Sickle Cell Initiative have been trying to put together a collaboration partnership with someone to be able to make that happen. And we're not done with our efforts yet. But I think during the break you said something that made me want to come into this, and I do believe that you think that that would be something good.
I think there are a lot of disease processes that could use some sort of familiar face. So it's one of those things where things like sickle cell, especially where we were talking about before, hey, your general presentation may not be the same as how you're feeling at the time. If you have a place where everyone knows your name, a la Cheers, it's one of those things where they're going to get to know you and know you, how you present with certain things, and know that you're going to get taken care of. And I think that's probably where a utopia would be, hey, I have sickle cell. I know that there's this center that I can go to if I'm having a problem, or if I'm just needing a checkup or whatever it is. And they can also deal with some other problems as well. I mean, I think that's the other big thing is sometimes we have these centers that do one thing really well, but then they farm out other things to other physicians or other providers. So if you've got diabetes and sickle cell, they may not take care of your diabetes very well. And if you're not seeing someone for your diabetes, then hey, you're gonna get taken care of. I mean, honestly, a place like Ortho Indy, the hospital on the north side, to be able to have a walk-in urgent care for injuries, to be able to also say, hey, we're bone specialists and we're going to take care of this, but we also have medicine doctors that will help us take care of your chronic issues. That's the kind of stuff that a patient with sickle cell would probably find, at least I would think, would find very, very attractive as far as wanting to get complete and comprehensive care. You may not get it from the same person, but at least under the same roof, you're going to get the kind of comprehensive care you need to stay healthy and stay productive. And I think that's probably the big thing.
So if you were able to participate in our town hall and you were asked that question, you would probably support it then?
Absolutely.
Okay, great.
Saying without any knowledge of how much it would cost, that's
always the problem. There's that cost.
Absolutely,
there's that cost. But that's the reason why we're pushing is that back in 2003, Congress passed a law that provided funding for the development of some comprehensive sickle cell centers, but that funding ran out in 2009, and there have been no centers developed. And when they were developing, there's several in Ohio, Michigan, Illinois. There's none in Indiana, and there has been some effort on the part of some Congress people to try to get some more funding for the program. That hasn't happened yet. Congress hasn't been responsive to it, but certainly if they do, that would help grease the skids and say, this money is exclusively to help you develop the center. So we certainly would be involved in that if it would happen, because the way the model for the Comprehensive Sickle Cell Center includes the providers, but it also includes social service agencies as a part of it to help people with the other issues that come with sickle cell. And so we definitely believe that we should have that here in the Indianapolis area, and we're fighting to see if we can't make that happen. Speaking of the sickle cell patients that you see in your emergency department, is the number one reason that they come in for pain?
Yeah.
Is that it?
For sure.
Yeah.
Yeah, I would say in varying sort of degrees. I mean, sometimes it's a typical crisis. Sometimes it's atypical for them, but still a pain crisis. I would say the incidence of some of the more severe, the things we as emergency physicians are taught to look out for, the more severe stuff, the acute chest syndrome, the aplastic crisis, that kind of stuff, are way low compared to the pain crisis. Now, if I worked 100 yards down the road at Riley, I probably would see a little different presentation and more of the splenic sequestration, where they're going to have acute anemia, that kind of stuff. But for the most part, like on my end, on the adult end, the things that have happened to the spleen, that have happened to the gallbladder, have already happened.
Right.
So I'm seeing more of the pain issues in that regard. Now, number two would probably be infection.
Okay.
After that. So,
okay.
Yeah.
And typically pneumonia or anything like that? Is that what you're talking
Probably more often pneumonia than anything else. So, it's one of those things where the concomitant, or the incidence of having pneumonia and acute chest crisis is pretty high. So it's one of those things where it's hard for us to tell whether you have one or the other, so we end up treating you for both. So a lot of times I'll say pneumonia, but it may be acute chest syndrome, but we're treating pneumonia as well. So I would say that's probably the second most likely.
The article that I referenced, the 2010 article by Dr. Youssef, it also says that research found that sickle cell patients had to wait an average of 307 minutes. Now, this is nationally.
Right.
It had an average of 307 minutes, which is a little over 5 hours to be seen. How would you rate your emergency department's performance in relation to that national average?
We're way better than
That's good to know.
So our median time door to provider is right around 33 minutes. So now, that being said, that's median time. So it's one of those where, well, if you're coming to visit on a Monday afternoon, it might be an hour and a half. But when we were back in the old Wishart, back when I was a resident, 6 hours, 7 hours, easy for most people to get seen. But now, I mean, the juice has been turned up, so to speak, and it's a national quality measure as well that patients get seen quickly. So the efforts to try to get patients to providers so that they can get seen in a timely fashion has definitely made a big dent. And since we redesigned our process flow, I talked about that earlier, in regard to not having a triage nurse and all that stuff. We went from a median time of around 95 minutes down to 33 minutes. So it's one of those things where we definitely have made huge strides now. Like I said, people will always say, well, I had to wait 2.5 hours or 3 hours. Well, every now and then there's going to be the time, especially afternoons when
that's how you get meetings too.
Getting people upstairs, that you're going to have some waiting. But the medians for sure is definitely way lower than.
Do you track that with the other hospitals in the area? Do you comparison?
I believe we do. Now there are things, the University Health Consortium that looks at certain types of hospitals that are academic or comparable, and they look at wait times and they look at throughput times regarding both arrival to discharge, arrival to admission, that kind of stuff. And so we actually measure this on a regular basis, and we compare ourselves to places like Grady, Cook County, or I guess now they call it Stroger or whatever it is. But yeah, it's one of those things where, for the most part, we compare ourselves. And for as far as our throughput times, we compare really favorably compared to a lot of the big county hospitals.
Great.
So we do a pretty good job.
Great. So, would you please share your emergency department's protocol for treating people with sickle cell? Today's protocol. What do you do first, and why is that?
So really, for the most part, when someone comes in, especially if they're in a pain crisis, we'll look at, by and large, we want to do our blood work to start out with, mainly because we don't want to miss the other stuff. Pain crisis is one of those things where that's not a complex issue. It's complex to get them out of it, but it's not complex to deal with in that regard. But the other things, the acute chest syndrome, the aplastic crisis, that kind of stuff is what we're looking for otherwise. So laboratory values we get, but that's not really to make us to allow us to start treatment. The treatment starts concurrently with the laboratory testing. A lot of times we won't get the testing back for an hour and a half or whatever it is, and then after that it's pain control and some fluids, not a ton of fluids. Really, for the most part, there isn't a defined protocol, and I would say that's probably I'm not going to conjecture that. I would say that's probably true, at least in our emergency department, that not a person goes and does it the same way. There are, I'm sure, other places that have a higher population of sickle cell disease patients that do have treatment protocols. I know there's literature out there that says, hey, this is the ideal methodology of how to treat a pain crisis, how to treat all that stuff. We aren't there yet, and that's one of those things.
That's one of those things we're working on with you right now to try to get you there, because we do have the NHLBI recommendations for treating people with sickle cell that we're working with getting into your hospital, and I want to thank you for that.
Absolutely.
The open and welcoming that you've given us with regards to this effort is very commendable, and we thank you for that. We are attempting to share this information, which is very valuable and will help people start from a more standardized place. And I always recommend that as we do this is that these are recommendations for you, and certainly patient by patient, you can make your own modifications based on your own professional judgment, but at least you've got somewhere to start, and that's what this is about. So thank you for being open to working with us on that.
Absolutely.
So at what point do you decide whether to admit a sickle cell patient?
Well, sometimes it's easy. Sometimes it's not so easy. So the easy ones are the ones that have the things we look for.
Okay.
So if someone's has low oxygen percentage in their bloodstream, and they have an abnormality on their chest X-ray that looks like a pneumonia,
that's easy.
You ain't going home.
Yeah, that's easy.
If your hemoglobin level is way below where you normally live, you ain't going home.
Okay.
So those kind of things are fairly easy. The more complex ones are the ones we see most often, the pain crisis. So it's one of those things where, how much is too much to get somebody out of a pain crisis, and when is it going to take more than just a 2, 3, or 4 hour stay to say you can go home? And that's probably where we as emergency physicians are at a disadvantage, because we don't know you. We don't know what you look like on a regular basis. We only know what you look like when you are here saying you're having a pain crisis. And that's why it's important to have, when we go back to it before, sticking with one hospital system, because if I can easily get a hold of your hematologist, it's going to make that transition so much easier, and they can say, hey, this is atypical for them. Let's bring them in, and we'll deal with it. Or what, I've been having some trouble getting them into the office. I'm not really sure if they're following my treatment plan appropriately. How about you do this, this, and this?
Okay.
If they're paying somewhat better, send them out, and I'll see them in clinic. However, if I don't have a relationship with your hematologist, or if I don't know how to get a hold of them, or if they're not well known to the system, then it's much, much harder for me to say, hey, Dr. Smith, I have patient XYZ here. This is the third time they've been in. Is there something different we can do? Is there something we can try? Or is this something that you're suspicious that we there's on an outpatient basis that they're not doing that we can try to help rectify. And so that's where it's almost like us walking into a surprise party blind and saying, surprise. I don't know what the surprise is going to be. Hopefully it's a good surprise. But that's kind of how we work on a regular basis, is what do we need to do to figure out what's wrong with you, and hopefully we know the people that can also know you better so they can tell us more about you.
Okay. We're going to take one more break, and then when we come back, we'll conclude our discussion with Dr. Tyler Stepsis. This is the Sickle Cell Action Network. I'm Gary A. Gibson, your host.
Mast Therapeutics is leading the way in developing treatments for sickle cell disease. We're proud to sponsor the Martin Center Sickle Cell Initiative in its mission to provide leadership, education, and support services to the sickle cell community.
Yeah, for the most part, you're right.
Well, welcome back to the Sickle Cell Action Network. I'm Gary A. Gibson, your host. We're speaking with Dr. Tyler Stepsis, Assistant Director of the Emergency Department at Eskenazi Hospital here in Indianapolis. And we're getting ready to start wrapping up what has been a great educational conversation with Dr. Stepsis. Again, thank you for being here, and thank you for sharing your knowledge and wisdom with us. You seem to be a very caring physician, and I'm sure that you would prefer for sickle cell patients to be able to avoid coming to the emergency department, because it would mean that as long as they aren't in the ER, their condition is somewhat under control. But do you sometimes suspect that some of those trips to the ED could be avoided in the first place if patients were more compliant with their doctor's instructions?
I think yes. There are certain patients that we see that, unfortunately, like you said, we have to take people at their word. So if they tell us they're taking their medications, we have to assume they're taking their medications.
Right.
There are very few, unfortunately, there's some, unlike a seizure patient who says they are taking their seizure medicines, although their level is completely zero on their blood work, there's no good way for us to say, hey, are you taking your hydroxyurea? Are you taking these other medications? Are you on your antibiotics? What are you doing to help your health? And sometimes it's as simple as, like we talked about before, being able to afford the medications, being able to afford the doctors' co-pays.
Right.
That all adds up.
That's a big deal.
That's.
I'm glad you recognize that. That's a big deal.
Yeah, we have to, unfortunately, because we see the ramifications of it, unfortunately. Right. So it's one of those things. I think we all know that there's not going to be a sickle cell person in the world that has no ER visits in a year. That I would imagine they probably wouldn't have sickle cell if that was the case. But to be able to say, hey, I'm well controlled. Hey, I have a relationship with my primary hematologist or my primary care provider, is, I think, all we can ask for as emergency physicians is hey, if we can get you to where you need to be so that and once again, I go back to function. I wish we could get rid of that pain scale, 0 to 10.
Yeah, a lot of people don't like that.
Everybody's a 10 in our place, but if we could say, how functional are you? Is this something that limits? Can you do nothing else? Do you have to lay in bed all day, or can you get up and do things, or can you? Is this your baseline? That to us is way more important than are you a 10?
Right.
That unfortunately, so many people are 10. It's diluted anymore. So that's why I wish we could just get rid of it and deal with the more, because that's what people want, is they want to be back to normal, as normal as they can.
I bet you a lot of the sickle cell patients that are listening would agree with what you just said. I've heard it a lot of times. That pain scale that's just ridiculous.
It doesn't matter.
It doesn't matter, exactly. So, Dr. Stepsis, what advice would you give to any sickle cell patients or their caregivers who might be listening today? What steps can they take to improve their chances of having the best experience when they come to the emergency department?
Oh, that's a great question. I think the biggest thing that we would like is people being upfront about where they've been and what they've been doing.
Okay.
So, for example, hey, I come in, if I'm a sickle cell patient, I come into the Eskenazi Emergency Department, and I say I'm having my typical pain crisis. If you're telling me, hey, I was here last month with the same thing, or I was at St. Francis 2 days ago, or whatever. If you volunteer that stuff up front, that's going to make your whole visit change. When we have to find that out on our own, that all of a sudden makes that seem a little bit nefarious. So even though it's not, it's just one of those things where if you can, as much upfront as you can about it, that's going to make, number one, the tension's going to relax. Then also, just hey, these are my medications. It's amazing how people tell me to check the computer. I'm I'm asking you the question. I'm not checking the computer until I ask you the question.
Okay.
So
just answer the questions.
Just be honest up front with it. If you're not taking your medicine, tell me.
Okay.
I'm not going to withhold care, because it's going to make my job easier to help you if I know as much up front as I can. Mm-hmm. And then finally, it's especially if you're a caregiver, hey, this is the stuff that normally works. Now, normally in the emergency department, we think, okay, yeah, these medications are what works for you. Clearly, there's something else going on. But in a sickle cell patient, that tells me that this is where I need to start. So if I don't start there, there's very little chance that I'm going to be able to get you to where you need to be to help make you feel better. Mm-hmm. So I think, as long as you're able to say, hey, we'll throw out brand names here. I usually need this amount of Dilaudid, and I usually need some nausea medicine associated, because that's a lot of pain medicine for me to get at once, but it's what makes me feel better. Right. That at least tells me this is a starting point. Mm-hmm. And like I said, and now that you've told me everything up front about where you've been the last week, the last month, the last year, or whatever it is, that tells me that you have a good handle on your health care. You're responsible for your own health care, and that makes me help you that much easier.
Okay, great.
That makes sense?
Great, yes it does. Thank you. And is there anything else that we haven't covered that you'd like to add?
It's been great. It's one of those things where I'm sure we could talk for another 3 hours about this.
Probably.
But, for the most part, I think, we just need to be more cognizant of the sickle cell patient. We were talking about this before. There's a lot of competing interests regarding healthcare, especially opiate use in healthcare.
Right.
And unfortunately, I think sickle cell patients are
going to get hurt by this.
The casualties
They're
of this.
They're going to get hurt by this.
But I think if you can, the more people can be upfront with their health care, like just to go back to, if you can be upfront, if you can tell us what we need to know without us having to dig for it, things go so much smoother. So the long and short of it is we just, if everyone can be on good speaking terms, we're going to be fine.
Great.
I think that's the bottom line in that regard. So.
Dr. Tyler Stepsis, Assistant Director of Eskenazi Hospital here in Indianapolis, thank you so much for being with us today. Truly a pleasure and an honor to have you. You did so well, and I just asked you during the break, you did so well that we probably would like you to participate in our upcoming 2017 Indiana Sickle Cell Conference and talking about this very subject. Okay. Thank you so much for being with us.
Absolutely.
As always, we close the show with something for you to think about. And today I start with a quote that says, "I have no idols. I admire work, dedication, and competence." These are the words of Ayrton Senna da Silva, who was a Brazilian racing driver who won 3 Formula One World Championships in 1988, 1990, and 1991. He is regarded as one of the greatest Formula One drivers of all time. He was killed in an accident while leading the 1994 San Marino Grand Prix. Many of today's big-name open-wheel racing stars still idolize him and his accomplishments. "I have no idols. I admire work, dedication, and competence," Senna said. I think that this is a particularly appropriate message for all of us who are engaged in the fight against sickle cell disease. Last Thursday and Friday, I had the honor and the pleasure of interacting with so many people who work hard, remain dedicated, and demonstrate competence in what they do with regards to sickle cell. Among those who participated in our town hall meeting on sickle cell disease and our 2016 Indiana Sickle Cell Conference were Dr. Wanda Witten-Cherney from Detroit, Talana Hughes from Chicago, Jacqueline Robinson from Evansville, and Rosemary Britz from St. Louis. Each and every one of these women are the chief executives of their respective community-based sickle cell organizations, and each and every one of them are fully dedicated to their jobs. I also had the honor of interacting with practicing physicians who not only treat people with sickle cell, but do it with a dedicated passion that is so strong it fills the air like lilacs on a mild spring evening. Doctors like Julie Cantor Washko, Emily Meyer, Monica Curana, Brandon Hardesty are just that refreshing. Honestly, it didn't matter if I was speaking with them one-on-one or sitting in on their presentations. I was impressed to see that this group of doctors really understands sickle cell in a broader sense than most. In other words, they are dedicated to taking care of people with sickle cell, and they are dedicated to treating their patients with compassion and dignity. Dr. Marcia Treadwell, a Ph.D. who helps sickle cell patients in the San Francisco Bay Area, was there too. Those who know her respect her, and they also respect her dedication. You'll see what I mean when she appears on this show in late May. I was inspired by these individuals. Why? Because dedication is inspiring. Whether it's teammates on a basketball squad who are inspired when they see how hard their star player is practicing, or if it's activists who are inspired by the tireless efforts of their movement's leaders, dedication has the ability to grab people and pull them in deeper. So here's the good part. These dedicated people are using their intellect, their talents, and their skills to help people other than themselves. They're not in it for the money. They're in it for the service to others. Speaking of service to others, I must also say that our new friends at the Centers for Disease Control and Prevention are dedicated too. Dr. Craig Hooper and Dr. Mary Houlihan are using their positions within the federal government to make a difference for sickle cell, and they are doing it with dedication. During our town hall meeting, Dr. Hooper asked the sickle cell community to reach out to their congressional representatives so that Congress can become more aware and more responsive to the demands that sickle cell brings to its patients and their families. If you have sickle cell disease, you need to know that there are a lot of very dedicated people working on your behalf. They're dedicated to you no matter where you are. They're dedicated because they want you to gain a better way of life, a way of life that means fewer crises, less hospital visits, more social support, and yes, even a cure. These individuals do not need these things for themselves, but they would like to see them become available to you sooner rather than later. So, I think now would be a good time to write that letter and send it to your congressman. That's our show for today. Please join us again next week, same time, same station, on the Sickle Cell Action Network on RadioNext.tv, the Cool Groove site.